Welcome to the Manhattan Institute's EventCast, and thanks very much for joining us. I'm Brian Anderson, the editor of City Journal, and today we'll talk about how long-term care facilities bore the brunt of the COVID-19 pandemic and what we can learn from that fact. We'll draw upon recent writings on this important issue by City Journal and Manhattan Institute experts. Throughout the program, please submit your questions as we go along, and I'll try to include them into our discussion. Let me introduce our two panelists. First, Steve Malanga. He's the senior editor of City Journal and the George M. Yeager Fellow at the Manhattan Institute. Writing for City Journal, Steve has pointed to the inadequacies in American nursing homes. Even before the pandemic, as Steve notes, the U.S. fell short of protecting the elderly in long-term care facilities from infectious diseases. Our other guest today is Chris Pope. He's a senior fellow at the Manhattan Institute. Chris's research focuses on healthcare market regulation, hospitals, entitlement design, insurance market reform. In City Journal, Chris has highlighted successful, innovative approaches to staffing during the pandemic that can be a model perhaps for other facilities, so we'll talk a bit about that. So let me start with you, Steve. The pandemic has proved devastating for nursing homes nationwide. According to some estimates, as much as 40% of the overall count of people who've died in America during the pandemic were nursing home residents. But as you pointed out in a City Journal piece back in April, though this is a horrible and tragic situation, it's also not all that surprising. So what went wrong?
Well, first of all, let's talk specifically about the extent of it and where it went wrong. At this point, the best counts are that about 55,000 people may have died in long-term care facilities out of nearly 300,000. It's almost a 20% rate, a death rate, which is really shocking, although, again, this is our most vulnerable population probably. To talk about where it's happened, New Jersey has actually led the way. The states with the most deaths in nursing homes are New Jersey, New York, Massachusetts, Pennsylvania, Illinois, California, Connecticut, Michigan. The states with the highest percentage of deaths in nursing homes, some smaller states, New Hampshire, Rhode Island, Minnesota, Connecticut, and Pennsylvania. And we can talk a little bit about some of those states later on. However, here's the thing, the real shocker. In 23 states, more than half of all deaths have been in long-term care facilities. Now, the thing is, this was not completely unanticipated by some of us who were writing about this early for this reason. Early on, I wrote a piece called The Virus and the Economy, which really attempted to look at what were the health implications of shutting down the economy, because I wanted people to try to balance, understand there were health implications to shutting down the economy, and I wanted them to balance that with the predictions about deaths from COVID, because that's a very easy number to understand. One thing that impressed me while I was doing this is that a number of health experts, especially epidemiologists, were talking early on about those trade-offs, and they were afraid that a panic was emerging in America. And remember, this was mid-March I did this. They were afraid there was a panic that was emerging that was going to make us miss the target. And one prominent researcher said something that stuck with me. He said, our focus needs to be on the most vulnerable. He said, nursing homes, not schools. Immediately after hearing that, I went and started looking at what the record was, if you would, of nursing homes in terms of infectious diseases. Now, the thing about COVID-19 is it's new, it's unique, but it is basically a respiratory infectious disease. And every flu season, we have similar problems with pneumonia and the flu. And I looked at the record in nursing homes. There's a lot of academic research on this, and it's pretty startling. In particular, outbreaks are very common. The notion of states mandating protections is very erratic. Only about half of states even require nursing home workers to get a vaccine. And we have vaccines for the flu, and we're talking so much about how the vaccine is going to save us from COVID, but only about half of states require vaccines from nursing home workers. And if you look at it, that not even nowhere near 80 to 90% of nursing home residents themselves get vaccinated. You would think that in this vulnerable population that we would be focusing on that, and that nursing homes themselves would bring in doctors and make sure this is done, or nurse practitioners. The other thing is there was a lot of there's a lot of criticism of the record on nursing homes in terms of infection controls. And in some surveys, 40% of homes during flu season have essentially failed their inspection protocols for infection control. So all of this was very, very troubling. What then occurred quickly after this, more than anything, justified the concerns that we were starting to hear from some of these people, like this expert who said, again, nursing homes, not schools. And yet at the same time, and we'll talk about this a little bit more later, what I was hearing from some of the governors, okay, was that essentially this COVID was a nobody left behind. Phil Murphy, the governor of New Jersey, said, when people brought up the idea that this was mostly a disease targeting older people, he brought up the idea, we're not going to leave anybody behind. Andrew Cuomo famously said, when people suggested, what's the right focus here, he took that to mean, we're going to leave the elderly behind. He said, famously said or infamously said, my mother is not expendable. But the fact of the matter is, when you look at the history of the way we treat the seasonal flu, in which every year thousands of people, tens of thousands of people die in this country, and the way we treat the issue in nursing homes, we've never had an attitude we're going to leave everybody behind. And so that was very troubling, and the numbers we're seeing really reflect that. And we're not obviously out of it yet, so we'll have to see where this goes.
Thanks, Steve. Thanks, Steve, a lot. Chris, maybe you can follow up a little bit on what Steve just said about the particular vulnerability to COVID of the nursing home residents, why it's such an infectious environment, apart from the problems that Steve isolated. And then I'd like you to say a little bit about what role the finances and payment system at work in the nursing homes might have played a role in this crisis.
Yeah, well, Steve's obviously exactly right. This is not a new problem. It's something we deal with every year. The idea of large amounts of elderly people dying in nursing homes from infections is certainly not a new thing. Every single year, an average of 380,000 people die of infections in nursing homes. And really, we should have seen this coming. And I think Steve's right to make the comparison, what we sacrifice for schools, what we sacrifice to keep bars open, versus what we sacrifice to have nursing homes kept safe, secure, and doing the job that they ought to do. And we've clearly had a failure of political will, really, in terms of dedicating the resources and dedicating the sacrifice to protecting nursing homes that we've been willing to make for other sectors of society. And I don't think there's really much indication that that's going to change at all soon. The basic thing I think you can say about nursing homes in the COVID crisis, like so much of healthcare policy, is really the old adage: you get what you paid for. And when it comes to nursing homes, we really try and skimp. Nursing home reimbursements are very, very heavily. Nursing home revenues are very heavily dependent on the Medicare program, Medicaid program, to an extent that no other part of the healthcare system is. So if you think of a hospital, usually about half of a hospital's revenues come from private insurance, which is generally a very generous reimbursement source, generally supports a lot of intensity of care, means that no expense is spared in terms of safety, in terms of cleanliness, in terms of quality of equipment. But when it comes to nursing homes, the majority, I think about 52% of nursing home revenues come from Medicaid, and private insurance is probably only about 15% of nursing home revenues. And as with hospital care, Medicaid rates are very, very low. So on average, Medicaid pays about 89% of the average cost of looking after someone in a nursing home, which means the nursing homes have to scramble to get revenues from Medicaid, from self-paying patients, really to stay afloat. And they tend to cut corners. They tend to cut corners on staff. They tend to cut corners on safety. We saw in a lot of cases that personal protective equipment was often really absent. But also, when you cut corners on staffing, that really means that quite often homes are relying on sort of greater medical interventions. They're medicating residents who maybe or not to be medicated. If staff are overstretched, they're not really taking as much care with each patient as they ought to be. And so you end up with a lot of lapses, essentially, in what should be the provision of a basic service in an environment where any kind of disease can really spread very, very quickly. The idea that everyone has a personal room really doesn't apply to most nursing homes. Most rooms are shared. Most staff are visiting numerous rooms one after the other. And so if you look at if you sort of think about, there have been discussions of herd immunity, that maybe if 60% of the population catches the disease, then it'll die off. Well, in some nursing homes, we've seen it go like over 90% of people within the nursing home have gotten the disease, just because people, whether they're asymptomatic or whether they're sort of dealing with whether staff are dealing with light cases, are going from room to room before they're really withdrawn from the nursing home. And pretty much everybody in many homes have been infected.
Thanks, Chris. Shifting gears a little bit, Steve, here in New York, the estimates are that as many as 6,000 seniors have died of COVID-19 in senior care facilities. And Governor Cuomo has come under some fire for this outcome. I'm wondering, what's your view of what happened in New York, and have we seen similar situations in other states?
Well, if you look in terms of the percentage of people in states dying from this, it's fairly high in many places. The controversy about New York is actually controversy that occurred in a dozen places, where governors or public health officials, as part of the administration, ordered essentially nursing homes to take back residents who had gone into the hospitals and then were released when they were thought to be out of danger. They were released in some cases without actually requiring that they test negative for the disease. This happened. It happened in New Jersey. It happened in Pennsylvania, and in different degrees. So some of the controversy is, number one, that staff in some of these places, first of all, the nursing home operators themselves in New York and other places vigorously objected to this, the idea of sending people back. In New Jersey, the kind of public health bureaucracy, meaning the longtime bureaucrats, not the actual administration, director of public health, a commissioner of public health who's politically appointed, but the staff kind of revolted against this. They've even sent letters, whistleblower letters, if you will, to members of the legislature in New Jersey, complaining that they objected to this, that the governor didn't listen to them, that this was not a good thing to do for obvious reasons. So essentially what happened was there was a panic. And this is where the whole idea that the panic was driving unwise decisions really comes into focus. Because in New York, they feared, and in New Jersey, that the hospitals were going to be overrun. And because they feared that, they said, we've got to get people out of hospitals as fast as we can. This occurred even though there was supplemental hospital beds available, even though, for instance, in New York, they built up a temporary hospital facility in Javits Center. They had the U.S. Navy ship come in. And many of those beds were never used, yet they were pushing people because there was this panic about almost a hospital bed apocalypse, if you will. And this is where the whole idea that we were kind of losing control, of the circumstances in the situation really becomes evident. Now, it's fair to say that there would have been a problem anyway given a couple of things. Number one, as Chris said, we were in the middle of flu season, and a lot of nursing homes didn't have adequate protective gear anyway. And I know there was a shortage of protective gear once COVID hit, but many of these nursing homes didn't even have adequate protective gear. We're in the middle of pneumonia season. We're in the middle of flu season. That clearly would have been a problem. There is no vaccine, obviously, for the workers. There's no vaccine for family members who were visiting until we realized the seriousness of the problem. Having said that, there's still a lot of criticism of those particular states, and in particular, first of all, just the idea of sending people who still haven't tested negative yet for the disease back into nursing homes, the most vulnerable to the most vulnerable population. You think, how does anyone make that decision? Now, in fairness, I guess you can say in fairness, New York State has released its own study of what really caused the problem in nursing homes, and they have concluded, not shockingly, that it wasn't that decision by the governor and the public health authorities. They've concluded that it was the workers. Their idea is that in some cases, they estimate that as many as almost 30% of all nursing home workers were infected, and they brought it in from the outside. Now, there are a bunch of people contesting this idea. First of all, there are people even people in both parties in New York State saying we need an independent study of this. But one of the reasons is it's an unusually high number of workers in a particular industry that got these infections. And the idea is, yes, there is a history of workers bringing infectious diseases into nursing homes, but it works the other way too. When you're sending people who are infected back into the homes, you're likely to infect the workers as well as the other residents. And those workers are working on 5, 6, 7 different residents a day, so they're essentially spreading it around. So so essentially the notion that it was the workers' fault, if you will, or it was an unavoidable factor, has gotten a lot of criticism. Also, this report controversially absolved the nursing homes. It said the nursing homes could do nothing to stop this wave. And that's upset a lot of people who are very critical of the past experience of nursing homes, because their procedures have been lacking, again, with the seasonal flu, with pneumonia in past flu seasons and past infectious disease seasons. And so the idea that this was just a train wreck, actually, that no one could stop, that the state couldn't stop, and that the nursing homes couldn't stop, or at least ameliorate, strikes some people as a little bit naive. So that's kind of where we are right now. Now, again, it's important to understand that it wasn't just New York. There were 12 states. New Jersey was another one, and New Jersey and New York lead the list of total deaths. And in particular, one of the things, again, there's some things that are upsetting about this. One of the things that I find very upsetting is that in New Jersey, they actually, when this first started, and people weren't even aware, the general public wasn't aware that the government had ordered the nursing homes to take back the workers. When these deaths started, and the state actually began a naming and shaming effort to name the nursing homes where lots of people were dying. Now, this was actually consistent with what was going on in New Jersey. If you drove around New Jersey during the pandemic, you see those electronic signs that are by the side of the road. They also had signs which said, "Don't be a knucklehead." Now, this is the governor. The governor was saying that the reason that the COVID was spreading across the state, because there were so many people, they weren't observing social distancing, they were being knuckleheads. This was another version of this. They're actually blaming the nursing homes. They're actually have a program of naming and shaming until it came out that the government itself had ordered people back from the hospitals into the nursing homes. So that, I think, is, has upset a lot of people. Let me just add another thing. Not every state did this by any means. Florida was one state that did something very different. Florida has still a large percentage of its deaths are in nursing homes, but the total numbers of infections and deaths in homes is much smaller. Now, here's the thing. Florida did a bunch of different things. They never, of course, put out this ruling, this executive order to send people back into the nursing homes. They actually did the opposite. What they did was, rather than worrying about hospitals filling up too quickly, when outbreaks began in nursing homes, they took everybody in those facilities, these are smaller facilities, they took everybody and they sent them to hospitals where they could be isolated and cared for and watched much more carefully. They even got a waiver from the federal government so that the people who had not yet tested positive for the disease could still be sent to hospitals and reimbursed at the rate that the federal government was reimbursing for COVID care, because they felt it was important to get these people in an environment where there was better care. Connecticut did something different, but in that they created COVID-only nursing homes to isolate their patients from essentially the rest of the population. It took them a while to do that, which is one of the reasons why they still saw a significant number of deaths, but they eventually did it. Now we're at the point, for instance, in Florida and a bunch of other states, where they're testing nursing home workers twice a week, and they're testing residents numerous times a week. And so that may account for some of what we're seeing in it as this kind of part of the wave slows down, if you will. The momentum in these kinds of deaths starts to slow down.
Chris, speaking of Connecticut, one of the things you wrote about in your piece on this is a kind of innovative assisted living facility in that state that really avoided, at least the last we checked, a lot of these problems. Maybe you could say a bit about that institution and what they did, and whether that could be a kind of model going forward for other such institutions.
Yeah, of course. I think a lot of the big challenges with the nursing homes has been we really underestimated what it took initially to keep the disease out. Like, the initial advice was wash your hands, a little bit of social distancing, maybe check people's temperature on the way in. And as we know, there are lots of asymptomatic cases. And so all it takes is a couple of asymptomatic staff members to go into the nursing home, and all of a sudden the disease is everywhere. Staff members are potentially living with other family members that have jobs as essential workers or that work in other nursing homes, or they're taking public transport into the nursing home every day. And so they're like, while much of the population is sort of social distancing or safely at home, nursing home workers are actually exposed to the disease a lot of the time because they're circulating in the community and really quite often connected to other people who are in high-risk situations. And our initial attempt to basically keep the disease out of the nursing home was pretty ineffective in so many cases. In New Jersey, 85% of nursing homes have had cases of COVID within the nursing home. And obviously, once the wall is breached, in a sense, then your best you can do often is just to pray that you get lucky. So what one facility in Bristol, Connecticut tried to do, the Shady Oaks facility, is they decided that they wanted to set up a perimeter around the facility and almost put themselves in a bubble and say that nobody comes in, nobody comes out. All the staff would be housed within the facility. They would stay there overnight, and they actually rented some trailers to be parked in the parking lot. They rented the house next door to house some staff, and they would make sure that the facility for the duration of the big wave would be cut off from the outside world, so that everybody would be safe, and that there would be no disease coming in and out. This was an assisted living facility, so it wasn't getting any money from Medicaid. It wasn't getting any money from Medicare. It was really a private pay facility. But what the owner did is he basically put up his own money to keep the facility secure. Now, part of this actually is, part of it obviously is kind of smart and sort of forward thinking, but then also part of it also works out sort of in a self-interested way, in a sense that it gets very expensive if you have many, many cases in your facility. It gets very, very expensive if your residents start dying and you're not getting paid. You're having to potentially keep sort of keep a disease out that's already within the facility, your exposure to lawsuits becomes much greater. And so securing the facility at the outset actually is in some ways a smart business move as well. The difficulty for other facilities is really just the liquidity problem to a large extent. Now, nursing facilities have very, very thin margins, profit margins, usually over the past few years, really less than 3% on average. And so their ability to put the outlays to basically pay hazard pay for staff to stay overnight, for staff to basically not go back to their families is very, very limited. What the Connecticut facility decided was that, you know, you have to make it worth staff's while to be away from their family for a couple of months. That was what they viewed. You got to basically pay them enough extra money that the staff can go to their families, can go to their spouses and kids and say, you know, I'm going to be away for a little while, but this is going to be worth our while as a family to do this. And that's what they did. And they basically rode out the wave in Connecticut while 2/3 of the nursing homes in the state were basically subject to cases. They kept it out of the facility very successfully.
Just a quick reminder that anybody in the audience watching can submit their questions below, and we will try to incorporate some of them throughout the remainder of the discussion. And with that in mind, here's a question from Neela. She wonders whether long-term care facilities have been equally affected, or are there certain demographic characteristics, whether wealth or race, that have made certain facilities more vulnerable to infection?
Well, the biggest vulnerability is obviously going to be associated with comorbidities. So long-term care facilities have there's a spectrum of acuity of medical needs that they treat. Assisted living facilities are generally people who don't have ongoing medical needs. And then at the other end of the spectrum, you have the skilled nursing facilities where there is constant needs for assistance, whether it's changing colostomy bags, constant medication needs, where you have patients who might have dementia, patients who have like emotional and mental problems, as well as severe needs for basic medical conditions that are almost life-threatening. And so with the spectrum of acuity in terms of medical needs, you also have a similar spectrum of vulnerability to the disease itself. Nursing homes in general cater to the most frail members of society, and this is partly why they've been so hit by this disease. It's almost like when the tide comes in, that the people who are the shortest get drowned first, in a sense. Like, these are people who are already in a bad in a very vulnerable situation. And so no, that it's not just that the environment of a nursing home facilitates the spread of the disease. It's the fact that these are people who are often in very, very bad shape. That's why they're there in the first place.
I'd like to go back to something you briefly mentioned at the top, Steve, on vaccines. You know, there are some encouraging news reports that a vaccine for COVID-19 may be on the nearer term horizon than we first thought. But you know, how is that going to work in terms of nursing home protection when, as you noted, there hasn't been always a widespread willingness among nursing home residents or workers to be vaccinated against the flu?
Well, let's put it this way. Even if there are no laws mandating, and I'm going to suspect that most states are going to mandate that for healthcare workers, that vaccine, I think that there's enough awareness and enough fear among nursing home operators and workers that you will see much higher vaccination rates with this. The bigger problem is going to be finding a vaccine for this. We don't know how, when the vaccine does emerge, we don't know how effective it's going to be with older people because they're going to have to they're doing separate tests to determine the what level of dose is necessary And, even with the seasonal flu, there's a dose for people over 65, which is a stronger dose, and that's been tested, and so it's not going to be a magic bullet, and it doesn't. And here's the thing: it doesn't matter if it is, because even when we have this for COVID, we're going to go back to the seasonal flu and pneumonia season, which occurs every year, for which we already have vaccines. And so the real question is going to be, coming out of this, do we just say, phew, we're done, and forget about it? Or do we say, these are the reforms that are absolutely necessary? Do those 50% of the states that don't even require vaccines for healthcare workers, vaccines that we already have, are they going to now require them for those diseases too? I think that's the larger issue. And there just are multiple weaknesses and vulnerabilities in these places that we have not accounted for in previous years. And a COVID vaccine isn't going to in any way fix those. And those vulnerabilities account for many, many people dying of something other than COVID.
Nursing homes face staffing problems. Chris, this is something you've noted. And the CARES Act has actually worsened the situation. Do you want to speak a little bit about that and what should be done about it?
Yeah, I think the CARES Act was the CARES Act, which was the major legislation which Congress enacted at the end of the spring, was really intended and sort of conceptualized as dealing with the economic fallout of the pandemic, really to provide support for people who go out of work, who lose their jobs, who are no longer able to, or who are required to look after their kids, to give them income that enables them to stay home and to do so. And that was really disconnected to a large extent from the disease fighting. There were titles to the legislation that were intended to sort of assist the medical effort, but they were and the way this works in Congress is that they were created by a separate committee and kind of stapled together and really developed independently from each other. And the problem with this is that it really undermined the incentive for nursing home workers, or it really kind of didn't strengthen the incentive for nursing home workers to go to work. And part of the upshot of this is that because your average nursing home employee who earns about $13 an hour could then earn more by not going to work, by staying home, by claiming the CARES Act funds. That caused many people who might have been able to make arrangements to still go into work, to still go to nursing homes, to stay home. And this is a problem because it's actually caused the staffing ratios in nursing homes to fall really quite substantially. And as we know from a lot of the literature, on research literature on nursing homes, the staffing ratios are really, really closely correlated to the quality of care that's received. If you're understaffed as a nursing home, it can feel a lot like spinning plates on the sticks, and you're not going to be able to do all of them. And we've certainly seen many cases come crashing down as a result.
We have a question from a viewer, from Kim. What can be done to give residents a greater say in their care instead of just being housed in a facility that isn't necessarily responsive to their needs and concerns? So I put that to both of you.
Well, one thing is, this is a choice that people make. Sometimes they feel they don't have another choice, particularly when Medicare or Medicaid is going to pick up the bill. Medicaid is going to pick up the bill. For a long time, we've tried to, in our society, states have tried to encourage other options, particularly in-home care. In-home care is sometimes a half to maybe even 60% cheaper than nursing homes, and it's a real option that people sometimes don't choose because their relatives would rather just see them in a nursing home. That's a real option. It's not an option for everybody in a nursing home by any means, and sometimes the reimbursement protocols for that are more difficult, so that it's easier to get the government to pay, if you will, if you just go into a nursing home. But that's a solid alternative for people. But there seem to be things mediating against it. And so a lot of people just wind up in nursing homes because it seems almost to be, the easiest alternative.
Chris?
Yeah, Steve's right that that's definitely been a big issue that the policymakers have talked about. The issue, the big problem from a policy point of view is what's known as the woodwork effect, which is, on the one hand, no one really goes to a nursing home because they want to be in a nursing home. It's generally something that the elderly really resist. But a lot of the services that are helpful to keep elderly people in their own homes, healthy people might even like, who wouldn't want someone to clean their house for them, who wouldn't want somebody to help prepare meals for them or do shopping and provide those kind of general assistance with living needs. And so it's been very, very hard to sort of put almost like boundaries around in-home services in such a way that it serves to save money overall. So the in-home services per case were probably about a third of the cost, maybe even less than the cost of nursing home care. But because the volume increase that it induces is so much higher, it ends up costing more in total, unless it's very strictly sort of targeted at the ones who are sort of on the cusp of being able to sustain themselves at home or with assistance. Most states are now doing this, but that's a little tricky. The one big challenge that I would say in terms of choice of nursing home is that we really don't have a good competitive market for nursing homes. This is in part because of certificate of need laws, which basically create artificial shortages of nursing home spaces. Part of the theory here, the theory is almost twofold. One, it's like a desire to basically limit budgets, like a sort of an imperfect way of limiting Medicaid spending has basically been an attempt to limit the amount of nursing home places, and in the view that it will constrain capacity, constrain the aggregate volume of people who are going into nursing home and keep spending down in that respect. And then secondarily, the view has been that if you sort of limit the amount of nursing home places, then you don't have so much excess capacity in each facility, which means that overhead costs are spread over a higher patient population. Now, these two dynamics basically mean that every nursing home, there is almost a shortage of nursing home places, and so every nursing home is almost guaranteed a full quota of patients, or like they don't have to do much to attract patients. And in many cases, they can cut costs and quality and still be assured of the revenue, which is low quite often from the Medicaid program. And so there isn't a healthy competitive dynamic that you might see in many markets where there is a reward for quality, but instead you sort of have this sort of artificially suppressed volume, which sort of suppresses or sort of reduces the incentive for facilities to increase quality and to cater to the needs that individuals might be looking for.
Earlier, we had mentioned the problem of infection prevention in nursing homes. And one study showed that I think staffers at only about 3% of nursing homes were adequately trained or certified in preventing infections. What could be done to improve that in terms of training, in terms of funding streams, but it does seem like a big part of the problem. Steve? Well,
it is a big part of the problem. And again, the problem, what it goes back to are the fact that these homes are operating on very, very short margins, very, very small margins, and that the majority of their reimbursement is coming from from the federal government, from Medicaid and Medicare, and that they are expert at pushing reimbursement rates down. I mean, that's how they save money. Whenever we talk about saving money through those programs, it's just we're going to pay doctors less, we're going to pay hospitals less, and that's a big problem with nursing homes. Let's face it, you know, states tried for, I'm going to go back 15 to 20 years, states tried to encourage their residents to start to buy long-term nursing home care, long-term care insurance. It hasn't gone well. It's turned out to be far more expensive, and people just essentially don't buy it, and as a result, they rely on the government. So there has to be probably another funding stream specifically for that. Maybe Chris has some ideas about what that is or where that can be, but that's, that's an enormous problem.
That's a nice preview of a paper that I got coming up in the next month or two. The core problem with long-term care insurance is that the eligibility for the Medicaid benefit is so loose. You're basically, to qualify for Medicaid long-term care benefit, you're not expected really, there's no restriction on eligibility, even if you have a house with home equity up to $840,000. And so what happens is, if you qualify for Medicaid, Medicaid will pay for the nursing home, will pay for the home health in many situations. But if you then want to buy long-term care insurance, you lose the Medicaid benefit. And so you're mostly paying for a service that you would be getting anyway. So you have to pay for the whole amount of the service that you will be getting through Medicaid, plus maybe theoretically a little bonus in quality if you wanted to get to a better facility. But in practice, it's worked out that it's effectively like you can think about it as like the fact that you stand to lose the Medicaid benefit, or the value of the Medicaid benefit when you buy long-term care insurance, is almost like a 60 to 70% tax on the purchase of such insurance. And so that's basically done what you might expect it to do, which has caused that market to collapse and basically crowded it out. The one thing that I think is really worthwhile as a solution to this is if you instead kind of do what I think conceptually everyone understands and kind of wants the Medicaid long-term care benefit to do, which is to provide a real good quality safety net for people who generally don't have any ability to purchase private insurance or any ability to sort of purchase coverage for their own care and good quality care. It's not like people who are higher up in the income spectrum actually think that Medicaid is providing a good quality long-term care. So if you segment it so that people who are in the middle class and above have the ability and the incentive to purchase private long-term care insurance, that can create a thriving private market that provides the adequate revenues to reward quality nursing homes. And if you do that, it takes all the sort of middle class and up out of the pool of people who are drawing on Medicaid funds, which can also mean that the Medicaid funding can go so much further on the people who really do need to be in the program. So the solution is a matter of being much more strict about the eligibility for the Medicaid benefit. Not saying if you have a house up to $840,000 you don't have to contribute anything to long-term care, but basically saying we're going to have a Medicaid long-term care eligibility that's really going to be limited so that it's people who don't have the ability to buy insurance for themselves, and then expect people who are in the medium and upper incomes to provide for themselves. This is why we have sort of a thriving private market in most of healthcare. We say if you're able to provide for yourself, you should be expected to do so and to purchase your own insurance. That ensures that there's a lot of private resources coming in, rather than having a fixed pool of Medicaid dollars that are expected to be stretched to cover the whole of society, which is the problem that we've ended up with in long-term care, which is in some ways the sort of classic socialized medicine problem of having a fixed pool of resources that's supposed to cover everybody.
I'd like to get a few questions from viewers in. Here's an interesting one from Peter. New York, he writes, changed its method for accounting for nursing home deaths retroactively in early May to only count people who die in the nursing home. Someone who is transferred to a hospital is no longer counted as a nursing home death in New York. Have you looked into what the actual New York nursing home death number might actually be? It's even higher than the already awful number, is the implication of that question. Is that right?
It's not just the implication, it's probably a fact. It's clearly a fact. New York counted nursing home deaths in ways that other states did not. So the idea, here's simply explained. I think the question actually explains most of it. If you were in a nursing home, you got very sick and were sent to the hospital, you were not counted as a nursing home death. Even though you had gotten, even though you had been infected in the home and may not have gotten to the hospital. Certainly early on, people weren't being sent to the hospital until they were near critical condition. Other states have counted at people who were infected and and later died, infected in nursing homes and later died as nursing home deaths. So there's no question that the number of New York deaths would be higher. The problem is there's no way of going back and actually figuring that out. A number of different people who studied this just to come up with the nationwide numbers, because the numbers that are coming from government aren't great. They've used various databases just to come up with the basic numbers. Haven't been able to kind of determine what this is. It's possible that if there's ever an independent study commissioned by the state, that maybe we'll actually look into this. But right now, it's pretty clear that they undercounted significantly the number of nursing home deaths. Excuse me.
Hammond of the Empire Center up in Albany has suggested that a good way of getting maybe an upper bound on this amount is to look at the change of vacancy rates in nursing homes. Those increased from about 8% in usual times to over 20% this year after the COVID pandemic. Now, part of that is actually also the fact that people have been reluctant to put people who've been reluctant to enter into nursing homes, and then also there's been fewer just elective surgeries that have been sending people to nursing homes as post-acute care. But the one thing I think is kind of interesting about that figure is that when you look at New York's performance on that, it's actually not that much out of line with other states, with Pennsylvania, with Massachusetts, or New Jersey, that have suffered similarly. I think looking really we've certainly heard a lot about why New York has done some things wrong in terms of sending people back into nursing homes in hospitals, and I'm sure if they had to do it again, they probably would not do so. But there's yet little in terms of hard data that really shows that New York is necessarily or even visibly an outlier relative to other states in the region.
Here's a question from Sandy. What about cases that have recovered? So people in nursing homes who've had the illness, who've recovered, are they going back to the same home? What is being done with them? Do we know?
Oh, well, first of all, on average, about 75%, if we consider recovered, meaning not died, about 70%, sorry, 80% of people in nursing homes recover. Whether they recover with, serious, complications and how long they live after that, we don't know. But at present now, what's happened is most states are now requiring that a person test negative at least once, in some cases twice, before they are sent back. So presumably at that point, they're no longer infectious and they're back in their nursing homes, whether, I don't know, families have the wherewithal to take them out after this or whatever. But the recovery rate, I guess, the only evidence we have is the number of cases and the number of deaths is about 80%. And now we are trying to certify that these people actually are virus-free before we send them in. And presumably they also have antibodies now, but which might offer some future immunity.
Here's another question. This one's from David. This is a kind of technical question. So has the certified nursing assistant, the CNA, hindered or improved care for seniors?
Well, there is some evidence that certification is associated with a better quality of care. When you think of long-term care, it really does run the spectrum from things that are basically sort of activities that a spouse would be able to do for an elderly relative. The essence of long-term care is really sort of another person providing or compensating for an individual's frailties for activities that a healthy individual will be able to do by themselves. But it also runs up to sort of medical care. And there's a sense that if you're an elderly relative and your spouse is frail, that you will start to perform tasks that are more medical in nature. There will be bandaging. There will be, you'll be constantly dealing with a medical condition, and so there is some sense in which that's that's useful. I think in the case of the coronavirus, I mean, we're like, this is obviously a very, very serious medical condition for which, like, being a nurse is not necessarily going to change the outcome of any case. If someone needs hospitalization, they need hospitalization, and a higher level of certification is not necessarily is unlikely really to lead to a lower transmissibility, and it's not going to stop people getting sick in the first place. So I think in the specific case of the coronavirus, I don't think it's really going to have had much effect. But there are certainly, if we think about like the broader story that Steve was talking about, the fact that we just in normal times have a real big problem in nursing homes with quality, I think there you start to think that having higher levels of staff quality, staff training is actually might have some impact on outcomes.
Well, we're almost out of time, so let me ask a very general question to both of you to conclude. Cases have continued to rise in a number of states. I would say a majority of states right now. It is possible that we're going to be hit with a second wave of COVID-19 here in New York in the fall. What do you see in terms of the near and long-term future for nursing homes? Do we have a better sense now of how to go forward? Are there policy movements afoot that could make things a little better if we go through this again? So Steve, I'll start with you.
One thing I would say, which is also, I think, in a way, an answer to a question from Ben, which was, what's the ideal policy for nursing homes, is we are inching our way towards that. There are a couple of things that we should have been doing from the very beginning, which we're doing now. Where, again, I said this before, we're testing the workers several times a week. Number two, we're actually checking residents several times a day for symptoms, including temperature checks, and we're testing residents. Those things are, these things enable us, first of all, to see who's positive very quickly. We also now have a route out of nursing homes. They have been they've geared up with their protective equipment. So beyond all of the ideal kind of solutions long term, like better reimbursement and higher levels of staffing and better care, there's stuff that we're doing now that, we, believe it or not, we weren't doing in March, we weren't doing in April, and we weren't even doing in some places in May, including just checking people for symptoms, testing people every day, and no governor is going to say, to a nursing homes and ever again, at least during this pandemic, you have to take people back before they've tested negative for the virus. So those things alone, I think, are probably a fairly big leap forward.
Well, I completely agree with Steve, actually, on that. I think that, firstly, get the basics right, the things on PPE, protective equipment, the testing that we really should have been doing from the outset. Now we're actually a little bit more prepared. Those are going to get done. And then it's just basically the financial issue, making sure that these homes have got the money. Often, it's not like these are bad people that aren't trying. They're just incredibly stretched for resources. And that kind of comes to the final issue, and probably the crux of the matter, is how much do people care? Are we willing to just allow nursing homes to be like a place that you will avoid and a place that you really want to just kind of allow to fall apart in the way that we have? Or is there going to be some kind of political mobilization and maybe put these a little bit higher up the list of political priorities? Are we going to start, as to sort of reflect Steve's earlier point, which I thought was the best one, is we care a lot about schools. Are we going to start caring equally about getting nursing homes right in the future? It's not a healthy situation. In a year when we get vaccines, nursing homes are still not going to be completely fine.
I wanted to thank Steve Malanga and Chris Pope for your informed commentary today. And I want to thank all of you for joining us today. Please consider subscribing to the Manhattan Institute's newsletters, making a contribution to our mission. We have posted both links for doing so right in the comments window on your screen. So thanks again to both of you, and thanks everyone for joining us again today.